Let me tell you about a patient. I'll call her Eleanor. She was 72 years old when her daughter first brought her to my office. A retired English teacher, sharp as a tack her whole life. The kind of woman who could recite Wordsworth from memory and still beat her grandchildren at Scrabble. Then, over about 18 months, something shifted. She started repeating questions she had asked 10 minutes earlier. She left the stove on twice in 1 week. One Sunday afternoon, she got lost driving home from a grocery store she had visited every week for 20 years. Her family thought it was Alzheimer's. Her primary care doctor thought it was Alzheimer's. By the time she sat across from me, she was already being measured for a memory care facility. But when I looked at her medication list, I saw something her other physicians had not paused on. She was taking 7 prescriptions. Each one on its own looked perfectly reasonable. Together, they were quietly suffocating her brain. Here's the thing nobody told her, and this is what I need you to hear right now. What was happening to Eleanor is happening to millions of adults over 65 in this country. And it is preventable. It is often reversible. But only if you understand what is actually causing it. I'm Dr. Evelyn Ashford. I'm a board-certified neurologist. I completed my fellowship in cognitive disorders at Johns Hopkins. For the last 28 years, I've practiced at the Northeast Neurology Institute, where I specialize in age-related neurodegenerative disease. I'm the author of 2 books on brain aging and cognitive longevity. By the end of this video, I'm going to tell you the one thing on this list that almost no physician has time to explain in a 15-minute appointment. A 2015 prospective cohort study from the University of Washington found it more strongly associated with dementia onset than any single medication on the list. Don't skip ahead. The order matters. Before we go further, I want to be clear. This content is for educational purposes only. It is not personalized medical advice. Nothing I share today is intended to diagnose, treat, or cure any disease. If you are taking medication, do not stop or change anything without speaking to your own physician. The information here is the result of decades of clinical observation and peer-reviewed research, but your health decisions belong with you and your doctor. Before I go any further, do something for me. In the comments below, type the number that describes your situation. Type 1 if you are over 60 and you take 3 or more prescription medications daily. Type 2 if you've ever taken something to help you sleep, over the counter or prescribed. Type 3 if you've started forgetting words, names, or why you walked into a room in the last 2 years. I read every comment. The patterns I see in those numbers shape every video I make. Now. Number 7. A 2018 analysis published in JAMA Internal Medicine examining over 300,000 older adults found that long-term use of proton pump inhibitors, the drug class, commonly prescribed for acid reflux and heartburn, was associated with a significantly increased risk of dementia in adults over 75. PPIs are one of the most overprescribed drug classes in America. Many of my patients have been on them for 10, 15, even 20 years, often for symptoms that resolved long ago. Here is what most physicians don't have time to explain. PPIs do their job by suppressing stomach acid. But stomach acid is not the enemy. It is what allows you to absorb vitamin B12. And vitamin B12 is non-negotiable for the integrity of your myelin, the insulation around every nerve in your brain. Long-term acid suppression creates a slow, silent B12 deficiency. That deficiency damages white matter, the wiring that lets different regions of your brain communicate. When white matter integrity erodes, you don't get a sudden symptom. You get fog, you get word-finding trouble, you get the feeling that your thoughts are moving through molasses. I had a patient, Helen, 69 years old. She came to me convinced she was developing dementia. Her serum B12 was at the very bottom of the normal range, technically not deficient by lab standards, but functionally insufficient for her brain. She had been on a PI for 12 years for reflux that had resolved sometime in the Obama administration. Working with her gastroenterologist, we tapered her off over 8 weeks and supplemented methylcobalamin B12. At her 16-week follow-up, her cognitive complaints were essentially gone. The protocol I discuss with patients: ask your physician whether your P is still necessary, and if it is, whether your B12 is being monitored at least annually with both serum B12 and methylmalonic acid. That second test catches the functional deficiency that standard B12 panels miss. That's number 7. But what comes next sits inside the same biological pathway, and it surprises almost everyone. Number 6. The drug class known as statins, prescribed to tens of millions of Americans for cholesterol, has a complicated relationship with the aging brain. I want to be careful here. Statins save lives. For patients with established cardiovascular disease, the data is unambiguous. But for cognitively vulnerable adults over 70, the picture changes. A 2021 review in The Lancet Healthy Longevity flagged a subset of older adults who experience reversible cognitive symptoms, memory complaints, mental fog, word finding difficulty when on certain statins. The mechanism comes back to something fundamental. Your brain is roughly 60% fat by dry weight. Cholesterol is not a villain inside the skull, it is the building block of every neuronal membrane and every myelin sheath. Some statins cross the blood-brain barrier more readily than others, and in a small but meaningful subset of older adults, this can interfere with the cholesterol synthesis your neurons depend on. I had a patient, James, 74, pre-diabetic, who came in with what his cardiologist called early dementia. His Mosier score was 23. His statin had been switched a year earlier to a more lipophilic version. We did not stop his medication. I worked with his cardiologist to switch him to a hydrophilic statin that crosses the blood-brain barrier less easily. 12 weeks later, his Mosier was 28. The conversation to have with your doctor is not, should I stop my statin? It is, given my age and cognitive profile, is this the right statin for me? Those are very different conversations. Now we move into territory that 90% of physicians won't have time to explain to you. Number 5. Benzodiazepines. The drug class that includes most prescription anti-anxiety medications and many older sleep aids. A 2014 study in the British Medical Journal followed nearly 2,000 adults over 66 and found that those who used benzodiazepines for 3 months or more had a significantly higher risk of being diagnosed with Alzheimer's disease in the years that followed. Here is the mechanism. Benzodiazepines work by amplifying GABA, the brain's primary inhibitory neurotransmitter. In the short term, this calms anxiety and induces sleep. Over years, the brain compensates by down-regulating its own GABA receptors. The hippocampus, the seahorse-shaped structure responsible for forming new memories, is especially sensitive. Chronic benzodiazepine exposure has been associated with measurable hippocampal volume loss on MRI in long-term users. I want to tell you about Walter. 68, former executive, came to me for what his wife called personality changes. He had been on a benzodiazepine for 11 years, originally prescribed after a difficult divorce. His prefrontal cortex function on neuropsychological testing was operating at the level of someone 15 years older. We did not stop the medication abruptly. That would have been dangerous. Working with his psychiatrist, we tapered him over 9 months. By the end of that taper, his executive function testing had improved significantly. He told me he felt like he had woken up from an 11-year nap. Never stop a benzodiazepine cold. The withdrawal can be medically catastrophic. But if you have been on one for more than 3 months and you are over 65, The conversation with your prescriber is overdue. Number 4. The Z drugs, the newer generation of sleep medications that pharmaceutical marketing positioned as safer alternatives to benzodiazepines. A 2019 analysis published in the Journal of the American Geriatric Society examined falls, fractures, and cognitive decline in older adults using Z drugs and found risks comparable to traditional benzodiazepines, despite the marketing. The mechanism is nearly identical. Z drugs hit the same GABA-A receptor system. More importantly, they suppress the architecture of natural sleep. Specifically, they reduce the amount of deep, slow-wave sleep your brain needs for the glymphatic system to do its work. I want to introduce you to the term glymphatic system because I'm going to come back to it. Your brain has its own dedicated waste clearance network, a kind of overnight cleaning crew that flushes metabolic debris, including beta amyloid, the protein associated with Alzheimer's disease. The glymphatic system is most active during deep slow-wave sleep. Z drugs may put you unconscious, but they do not deliver the slow-wave sleep your brain requires for clearance. Beatrice, 76, came to me with sleep apnea and worsening memory. She had been taking a Z drug nightly for 9 years. Her sleep study showed almost no slow-wave sleep at all. Working with her pulmonologist and her primary care physician, we addressed her apnea with CPAP and tapered the Z drug over 4 months. Her MOSIA improved from 24 to 29. Number 3. Anticholinergics. This is a broad class that includes many older antihistamines, certain bladder medications for overactive bladder, certain tricyclic antidepressants, and a number of muscle relaxants. They are sold over the counter as well as by prescription. A 2019 study in JAMA Internal Medicine following nearly 300,000 older adults found that strong anticholinergic exposure for 3 years or more was associated with a roughly 50% increase in dementia risk. The mechanism is direct and devastating. Anticholinergics block acetylcholine, the neurotransmitter most central to memory formation. Acetylcholine is the molecule whose decline defines Alzheimer's disease. Every drug that blocks it, even modestly, is borrowing against your cognitive reserve. Most patients have no idea that the over-the-counter sleep aid they take 3 nights a week is in this class. Most patients have no idea that the bladder medication their urologist prescribed is in this class. Dorothy, 78, with a strong family history of Alzheimer's, came to me already convinced she was next. She was taking an over-the-counter nighttime sleep aid most nights, an anticholinergic bladder medication, and an older antihistamine for seasonal allergies. 3 medications, all pulling acetylcholine out of her system. We worked with her primary doctor to substitute non-anticholinergic alternatives for all 3. Her cognitive testing at 20 weeks showed measurable improvement. If you take nothing else from this video, take this. The term you want to ask your physician about is anticholinergic burden. Write it down. Let me pause for a moment. I know what you might be thinking. You're thinking I'm too far gone for this, or my memory is already declining. What difference does it make now? I want to tell you what I tell every patient who walks into my office at 70, 75, even 80. Your brain is not a fixed organ. It is plastic. It is responsive. It is, until your last day on Earth, capable of building new connections. The science is unambiguous on this point. The window does not close. I have watched patients in their late 70s recover cognitive ground that 3 different specialists told them was permanently lost. Your brain is not a passive organ. It is adaptive, resilient, and capable of healing when given the right inputs. If this is the kind of conversation you wish your own doctor would have with you, subscribe. I release new videos twice a week explaining the neuroscience behind the symptoms most people have been told to ignore. Number 2. Long-term opioid use in older adults. A 2020 analysis published in JAMA Network Open examined opioid prescriptions in adults over 65 and found that chronic use was associated with measurable increases in delirium, cognitive impairment, and falls leading to traumatic brain injury. I treat opioid-related cognitive decline almost every week. The mechanism is layered. Opioids depress respiratory drive at night, which means many older adults on chronic opioids develop or worsen subclinical sleep-disordered breathing. That oxygen deprivation, hour after hour, year after year, damages the hippocampus. Opioids also disrupt the architecture of deep sleep, and once again, you lose glymphatic clearance. The metabolic debris your brain produces during the day does not get washed away. Harold, 70, a Vietnam veteran with chronic back pain, had been on a daily opioid for 14 years. His daughter brought him to me because he had become a different person, apathetic, forgetful, withdrawn. We did not stop his pain medication. Pain that is undertreated is its own neurological insult. Working with his pain physician, we transitioned him to a multimodal protocol, physical therapy, and SNRI, topical agents, and a sharply reduced opioid dose. 8 months later, his daughter said she had her father back. That brings us to number 1. And here is where I need you to pay close attention, because this is the conversation almost no physician has time to have with you. It isn't any single medication on this list. It's something the geriatric pharmacology literature calls anticholinergic burden, and more broadly, polypharmacy with central nervous system effects. Let me explain what I mean. The 2015 University of Washington study I referenced at the start of this video tracked over 3,000 older adults for a decade. What it found was not that one drug caused dementia. What it found was that the cumulative dose of all medications with anticholinergic activity, added together over years, predicted dementia risk in a dose-response curve. Each of the 7 drug classes I have just described contributes. They each look reasonable in isolation. Your gastroenterologist prescribed the PPI. Your cardiologist prescribed the statin. Your psychiatrist prescribed the benzodiazepine. Your sleep doctor prescribed the Z drug. Your urologist prescribed the bladder medication. Your pain doctor prescribed the opioid. Your allergist recommended the antihistamine. No single physician sees the whole list. No single physician calculates the burden. Eleanor, the woman I told you about at the start of this video, was not developing Alzheimer's. She was experiencing the cumulative neurological cost of 7 separate prescriptions that no one had ever totaled up. We worked with her physicians over 6 months to systematically reduce her anticholinergic burden, restore her B12, address her sleep, and taper what could be tapered safely. Her MoCA score went from 21 to 28. The memory care facility deposit was refunded. This is not theory. This is cellular biology, and it is the single most important conversation you can have with your physician this year. Number 7 was the pie question. The lesson there is that stomach acid is not the enemy, it is the gateway to the B12 your brain needs. Number 6 was the statin nuance. The lesson is that not all statins are the same, and the right conversation is about selection, not cessation. Number 5 was the benzodiazepine question. The lesson is that years of GABA suppression rewires the brain in ways that can be partially reversed. Number 4 was the Z drug deception. The lesson is that unconsciousness is not the same as sleep, and your glymphatic system knows the difference. Number 3 was the anticholinergic class. The lesson is that the molecule blocking your bladder is the same molecule your hippocampus needs. Number 2 was chronic opioid use. The lesson is that pain must be treated, but the route matters enormously. And number 1 was the burden itself. The lesson is that no single specialist is watching the whole picture. You have to. Here's what I want you to understand. Your brain doesn't know how old you are. It knows what signals you are sending it. Every meal, every walk, every hour of sleep, every breath, every prescription. Whether you are 55 or 80, whether your mother had Alzheimer's or didn't, whether you felt sharp this morning or foggy, your brain retains a measurable, scientifically documented capacity to rebuild itself when you give it what it was designed to receive. And one of the most powerful things you can give it is fewer interferences with its own chemistry. Don't let the size of the change overwhelm you. Pick one item from this list. Just one. Print this video. Bring it to your next appointment. Ask your physician one question. Can we review my full medication list together for anticholinergic burden and central nervous system effects? That is the sentence. You don't need motivation, you need to start. All studies referenced in this video are linked in the description. Read them, print them, bring them to your next appointment. And in the comments, tell me which medication conversation you're going to have first. I read every single one.